This is a 36-year-old female, comes with a medial sided knee pain of long duration and there is varus deformity. We are demonstrating centralization of medial meniscus, and for this person we have done high tibial osteotomy for decompression of this medial compartment. We are seeing here that the posterior root and posterior horn of the meniscus is intact. There is a slight fraying at the attachment of the posterior root. However, she has pain only on the medial side and posterior root is intact as we checked with pulling the posterior part. We debrided whatever the remnants of attachment, and then we see that the meniscus is completely extruded over the medial side. We are now doing the rasping of the medial tibial plateau, and this is the sleeve for the anchor placement. We have made a small incision over the medial side where the maximum extrusion of the medial meniscus. You are seeing completely medial tibial plateau is exposed here, and bone is going to get contact with the femoral and tibial cartilage. Both are almost like bone on bone. She is very young. We are now using all suture anchors, not less all suture anchors. As we have put this anchor, we have not put over the medial on the cartilage. We could have put it to centralize more inside meniscus. However, we have put it to the corner. This is a lasso. We have taken the bites over the medial side where we want our threads to go. We are going to shuttle this lasso loop to the anchor loops, wires from the anchor. For this, it's better to use the cannula, passport cannula. Sometimes the lasso needle gets uh, tangled with the soft tissues. As we pull it, you see that meniscus has come to the central. We are not seeing the bone which was exposed before. As we tighten it, you can see the thread is here. We have not yet tightened it. When we tighten it, meniscus comes to the center. At least this thread, this anchor doesn't let meniscus to come out of the in the gutter. This is in extension. You can see that now you are seeing meniscus is centralized. There is no contact of femoral cartilage to the tibial cartilage. Meniscus is now come to the its original position, and we have come tracking this anterior part of the anterior horn. You can see anterior horn is intact, posterior horn is intact. This is purely medial meniscus extrusion. We have now centralized it. Although we have not centralized to the cartilaginous part, we have centralized to the anteromedial part where meniscus has to sit just medial to the capsule of the knee joint at the medial side. Now we are seeing that meniscus has come to its position. In extension, in flexion, we have cut the threads of the knot. Thank you for watching. If you have liked it, please like it. Please subscribe and like our channel. Thank you.